Okay, so it's past, so I think we could probably make a start. I can see we've got people joining already. Hi everyone for joining this FCI webinar with Public Health England on modelling excess mortality. Just got some housekeeping slides up at the moment, which you should be able to see. If you could keep yourself muted until the Q&A session at the end. We've got some keyboard shortcuts there as well to make things easier. You can write any comments during the presentations in the chat as it goes on, and we'll come to them in the Q&A. And you can also use the hands up function at the end as well and to ask your question. Yeah, the webinar is being recorded as well at the moment, just to let you know, and it'll be put up on the faculty website afterwards to watch back. So I think, yeah, I can pass on to Paul.
Start to catch up quickly. I know I put it in for next week, but it may not fit with everything else going on. That's my fault, because I was just, when I was talking to Hannah, I just said Monday to Friday.
So, okay, great. Yeah. Now that people are muted, yeah, I'll hand over to you, Paul, to introduce yourself and to kick off.
So, Sharmani, can you put on the slides? Okay. So, all right. So, then, Joe. Right?
Yes. Yeah. I think we're all good to go.
Okay. All right then. So first of all, I'd really like to thank the Faculty of Clinical Informatics for asking us to make this presentation. And we're hopeful that you're going to find it both interesting and thought-provoking. So I'm Paul Burton. I'm the Professor of Data Science for Health in Newcastle University, and I'm also a Fellow of the Faculty of Clinical Informatics. The work we're going to present to you today has been carried out under the part of Public Health England that's called the Public Health Data Science Group. And that's the group within Public Health England that I work with professionally under my NHS honorary contract. In a second, I'm going to introduce you to the presentation team. So these are Dr. Sharmani Barnard, who is Senior Statistical Advisor to the Public Health Data Science Group, and Sebastian Fox, who is Principal Data Scientist to that same group. Now, the truth is that these guys have actually done the work that we're going to be presenting. In respect to my mature years, I've basically been sitting at the back and trying to give occasionally useful advice. So I hope you're going to find this interesting. Okay, so the title of the talk is hopefully self-explanatory, and I'm going to start off by setting the scene. So next slide, please, Sharmani. Okay, so like us to imagine, in mid-February 2027 and towards the end of 2026, a new strain of coronavirus emerged, given causing the disease COVID-26, and critically, the virus causing this disease is seemingly resistant to vaccines created for COVID-19. So the question arises, if you look at the map, you can see that on the 10th of February 2027, you can see the distribution of the disease across the world. This is clearly a pandemic, started in China again. And the question is, how should the nation and Public Health England respond to this concerning situation arising? Now, I'm not allowed to make satirical political comments, but one thing that may immediately be asked is, how can it be possibly Public Health England in this scenario, given that we're talking 7 years ahead and Public Health England is going to shut down in April 2021? Well, the truth is that following the disaster of Brexit, it turned out that the 4 countries or 4 nations in UK all split apart after it. And when the new government for England came into play, they realised that they needed a body that had all the expertise and the areas and the access to data, etc., that Public Health England had, and they just felt that it was more convenient to recall it the same name, including many of the same people. So basically, this is the reason why Public Health England is thinking about this. And the key issue for those involved in Public Health England as one part of this is a robust strategic plans need to be put in place, and these are going to be based on what we've learnt during the COVID-19 pandemic. So first of all, there's going to be high quality systems for rapid case identification and contact tracing. This is will be one of the focuses of the government to make sure that these work really well. They're going to be ensuring that the health and social care systems are COVID resilient. They will be making sure that there's good population availability and population use of appropriate PPE. They will be taking full account of social issues such as education. They will be ensuring that financial and fiscal buffers are in place to mitigate the economic impact, and they'll be trying to develop a modified vaccine that is appropriate for COVID-26. But from our point of view in Public Health England, part of the key issue is to build into place systems to track the progress of the epidemic in as close to real time as possible, and also in parallel to be monitoring stress on the health and care systems during the epidemic waves as they come and go. And the whole purpose of monitoring the epidemic and the stress on the health system is that these can be used to help national and local politicians, public health experts, GPs, and other clinicians to work together to rationally guide and monitor the community health service and social care response systems to the evolving epidemic. I emphasise 2 points. I've underlined 2 things, local and GPs. And the reason for underlining those is that 2 of the really big lessons that came out of COVID-19 was that failure to properly involve the local politicians and GPs led to serious problems in working out how to strategically manage COVID-19. So this is now changed for COVID-26. And if we look at all of those systems that Public Health England is going to need to be put in, one of the key components of these will be to monitor excess mortality. And that's what we're now going to explain to you how it works. And so over to Sharmani.
Thanks, Paul. Okay, so why excess mortality? Excess mortality provides an objective and comparable measure of the scale of the pandemic by measuring mortality from all causes rather than just COVID. You're overcoming the issues in the variation of testing over time, but also between areas, and differential coding of death between individual practitioners, for example, and areas, as well as over time. But in addition to that, you're also measuring both the direct effects of the pandemic as well as the indirect effects. So those may be as a result of the measures that are imposed during the pandemic period. So the image I'm showing here is the weekly excess mortality in England up until July 24th from March 20. And you can see here, I'll be showing a few of these later on in the presentation. The orange part of the bar reflects the COVID excess, and then the white part of the bar reflects the non-COVID deaths that are in excess of what you'd expect during that time of that week. So the overarching methodology of any excess mortality measure is to compare the observed number of deaths with those that you'd expect during that time period. And the expected is based on previous years of data. But there's a number of different methodologies that you can use to create this measure. And most of the variation between these methodologies is generally around how the expected deaths are calculated. And the method in which you use to calculate the expected deaths really depends on what the excess mortality measure is going to be used for and by whom. So at the beginning of the pandemic, we were, Seb and myself were pulled down into the incident room and asked, to produce, well, among other things, this particular measure. And really what I'm taking you through today and what we take you through today is about the process, about how we developed it and the different decisions along the way. So the first being, where do you start? And the starting point here is around a needs assessment, thinking about who your stakeholders are. And for us at the beginning of the pandemic, we sort of mapped out who our potential stakeholders were. They were groups that wanted to model sort of outcomes throughout the pandemic, clinical directors in the NHS, politicians and decision makers, medical officers, regional directors of public health, academic groups, and groups specifically interested in disparities between subgroups. But all of these stakeholders have different needs. So you also need to identify what they need to use the measure for, whether they need a real-time surveillance or specific, surveillance among specific groups that isn't necessarily as timely or as real-time, or someone who just needs to quantify the total excess following the pandemic period. So the considerations when you're talking to your stakeholders that you want to think about is how urgently they need the measure, as in, because you can produce lots of different measures that meet different needs, but urgency, how quickly can the measure be produced, particularly from a standing start like we had back in March. The population of subgroups of interest, so they might be national or subnational, region down to UTLA. We've had requests for even lower. Age and sex groups, ethnicity, deprivation, excess by cause of death and place of death, and how up to date, how timely the reports are required. So whether you need a daily report of excess, weekly, for example, monthly, or just a cumulative excess following the period. So once you know who your stakeholders are, it's useful to start looking around at existing methodologies, particularly as we were starting from a standing start. What could we repurpose that's already up and going? And so in any country, you've got a load of surveillance activities that are going on. In particular, we had mortality surveillance for Euromomo that we contribute to across 24 countries in Europe. But there's also flu surveillance and other surveillance activity, like clinical activity. And we, in fact, have repurposed part of one of the clinical activity surveillance modelling techniques for something we do within our model for the time of year. So it's really useful to go around and have a look at what else is out there, whether you can just absolutely repurpose that, just change the data inputs, or whether you need to modify it for your needs. And once you've had a look at the different methodologies that are around, the next, and probably in parallel, the big question is, what data do you have available? So like I described earlier, with any excess mortality measure, you need the baseline period to inform your current period, but you also need the observed deaths in the current period. So you need to understand what mortality data you've got for the current period and for the baseline period, and then the frequency of the feed for the current period. So how often are you going to get your mortality data for your current period, and how up to date is it? So for example, in England, someone's death is registered with the GRO, and then that registration information is taken off to the ONS for coding, and then following that data could be available, or you could get a feed as early as on the day, at the end of the day from the GRO, or for yesterday. So there's different points. And then within your denominator data, then you may need to also have a look at the availability of denominator data. So the population at risk for both the baseline and the current period, if you're measuring rates or calculating rates. So keeping in mind that when I talked about subgroups of interest, you need to be able to identify your subgroups both in your current period and your baseline period in the mortality data. But if you're creating rates, you then need to be able to do that within your denominator data. So that's an added complication just to think about in the early stages, but also what you can't get from mortality data that you might also need. So for example, ethnicity isn't recorded on a death certificate. There's a lot of interest in ethnicity in our current pandemic. So asking yourself in the early stages, what other data sets may I be able to link to? Can I get those processes in place nice and early to obtain that information on subgroups? At this point, you may also want to start thinking about, maybe too much too soon, and that's for later development, but other parameters of interest in the model, for example, temperature, so heat waves and cold, very, very cold periods that you want to try and model out so that you are estimating the excess that's purely down to the pandemic or as much down to it as you can. and also flu if possible. So once you understand what data you've got and you make sure that you've got it comparable between the baseline and the current period, you need to start thinking about how you're going to calculate your expected deaths or your baseline. And there's a number of different decisions that you need to go through, and we try and map these out over the next few slides, and why you make one choice over another. And the first is your date of interest. So it may be really obvious to you that you think, of course, I want to know about when a date occurred, not when it's registered. But actually, there's a lag of time between when a date occurs and when it's registered. And by using the date of, if you're looking at timely information, the date of, if you take the date from the date of registration, which is the only time you can get it, you're missing a bunch of deaths that have occurred. So while date of death is the ideal date for epidemic surveillance, you don't know a death's happened until it's been registered. So it requires a delay correction to the observed figure that you get on registration. And that correction can add uncertainty to the estimate, and that's particularly important among subgroups if you're modelling down to very small areas. So you need to, if you are using date of death, it requires about 3 weeks before publication to estimate a robust measure of the number of deaths on that day. So date of registration is another choice. Using date of registration, you can produce robust estimates of subgroups quite quickly. It does require an adjustment around bank holidays and weekends within the model, so slightly more complicated in that sense. And it is worth saying that during the pandemic period, the time between the date of death and the date of registration has varied in a different way from how it has done in pre-pandemic times. So it causes some difficulty in the interpretation, but it's relatively minor when you're looking at the broader picture. So once you understand what your date of interest is, you need to think about your choice of data. I've talked about rates a little bit, but you could think about the type of death data in terms of counts of deaths per day or per week, but that doesn't account for the demographic shift over time. So it may be more appropriate to use rates. If you can identify rates and rates in subgroups initially, that's great. Or you're going to calculate rates using counts and denominators. Again, this all comes down to data availability in subgroups. When you understand whether you're going to use calculate rates or just use counts, you need to start thinking about how many years you want to put into your baseline data to estimate your expected. So you're taking previous year's mortality data, rates or counts. And when you're thinking about what you might want to include, it's really important to do some sensitivity on the mortality over those years, and making sure that you're not putting in particular outliers that are going to change your expected in a way which would not reflect maybe what's going to happen in your current period. So, I mean, for us, that was sensitivity analysis as well as consultation with mortality experts and people that have been looking at mortality for, oh gosh, many years, let's say, and knew the trends in mortality very well, and also the recent years of importance for us. And then once you've decided what years are going to go into your baseline, you think about the model parameters. So the subgroups of interest have to be in there, obviously, that you're going to put in. And I've given examples of those already. Seasonality is really important because you need to identify what time of year it is. You can use sine curves, or you can use something like what we do, which is the day of the week and the time of the year. Time of year is the bit that we've borrowed from one of our existing methodologies, the RAMI model in Public Health England. And that creates a smoothed month variable, so you don't get this sore tooth, for example, where the end of January behaves a bit like January and a bit like February, rather than all like January and nothing like February. So how are you going to create that time within your model? You need to deal with year-on-year trend and identify what that trend is. And then also put in other factors. So if you're using date of registration, you need to think about proximity to bank holidays, and regardless of what date you use, you might want to think of temperature or the weather or flu. So I'm going to hand over to Paul to talk about model type now.
Great. Okay, thanks a lot, Sharmani. Brilliant. So I'm going to take you through some of the key elements of the mathematical model that we use to effectively analyze and create the baseline. Now, the first thing about incorporating the baseline is that what you're trying to do with the baseline is, if we think of this as a data that over weeks. So, for example, if it took this current week that we're in now, then basically, and if we're talking about registrations, because we are going to talk about registrations because we believe that in this instance that we need to be focusing on as close to real time an analysis as possible. So we're going to work with registrations. And if we think about this week, so that's from the weekdays, which is when registrations occur, are from the 21st to the 25th of September this year. Now, if I wanted to know how many deaths I might expect to be registered over that period of time, then a very obvious way to do that would be to take the same week or the same equivalent week over the last 5 years. And by equivalent week, I don't mean the same dates, but I mean the dates starting with Monday and finishing on Friday, which is as close to our current one as possible. And then if we took the mean of those dates over those deaths over those 5 years, and that would be a very natural way to generate what could be viewed as the baseline. Now, because that is a very simple way to think about it, and one of its advantages then is that it's therefore very simple to understand how you create it. So that's excellent. However, there is the simplicity of it is also a major disadvantage of it, in that the reality is it's very easy to create it, it's simple to create, but it's actually very difficult to interpret. And that was a particular problem at the start of the COVID tracking for reasons that I'm going to explain now. So basically, the particular problems that arise around public holidays, and the worst public holiday of the year is Easter. And the reason for that is that, first of all, the public holidays in Easter affect 2 consecutive weeks. So in one week, you've got a Friday missing, and in the next week, you've got a Monday missing. And the reality is that the number of registrations that you can do if you drop a whole day off a week, it's not quite as low as 80% of what you could do if there was no days dropped, but it's probably somewhere around 90%. So basically, the weeks before and after Easter have a significantly reduced number of registrations every year. Then, to complicate things even further, in the 2 weeks either side of Easter, the opposite happens, because in order to prepare for Easter, people who are collecting the death registrations try and work as hard as possible in the week that's before the week before Easter. And so there's a high rate of deaths or a high rate of registrations in that week. And then 2 weeks after Easter, there's again a high rate of registrations, this time because they're still catching up on the low rates that occurred in the week before. So basically, first of all, Easter then has this sort of wave pattern where it goes high, then low, stays low, goes high again, and then goes to normal on either side. So that's the first problem. The second problem, however, is that Easter moves from year to year, and therefore you can't just line up the equivalent week in the previous year by doing the dates, as we were, for example, saying around this week in previous years. And if you actually look at the rates, the dates at which Easter fell over the 5 years before 2020, so in 2020 itself, the week before Easter, the weekdays in the week before Easter were the 6th of April to the 10th of April, and the ones afterwards were the 13th of April to the 17th of April. So both those 2 weeks in this year, there were low counts expected, probably the order of 90%. But if you look in the previous years where those 2 corresponding weeks fell, then in fact it turns out that for the week before Easter, in the 5 previous years, the rates were, it was a low week in 2 of those, But in the other 3, in fact, it was one of the high weeks. So it was either the week 2 weeks before Easter or the week 2 weeks after Easter. So in fact, the baseline, far from being low in that week on average, was actually higher than it should have been. So basically, we're going to be trying to compare low observed deaths with a higher than average baseline death. And in fact, the same thing, in not quite such a marked extent, relates to the expected deaths in the week after Easter, from the 13th of April to the 17th of April. So basically, by using the average comparison, just simply the average of the deaths in the registered in the equivalent week in previous years, then you end up getting a marked overestimate of the deaths that you should actually get in this year. And if you get a marked overestimate in the baseline deaths, that equivalently means that you're going to underestimate the number of excess deaths. And in fact, one of the things that was apparent in the early data that was coming out during the COVID epidemic was that those when the average was being used, then the excess deaths from those estimates were consistently lower than the excess deaths in ones that weren't using that approach. Now, the only other thing to say in relation to this is that you also, unless you do something specifically, as Sharmani said, in relation to temperature or to influenza outbreaks, then basically the simple average in the previous years will also not correct appropriately for them. So what we did instead is exactly as Sharmani said. We've got all the model components, which are the ones she listed, that are now also listed on the top right of this slide. And we're going to build those into a suitable mathematical model. We're going to estimate the impact of each of those components over historic data, and we're going to again use 5 years. And then we're going to apply these estimated impacts into the week that we're wanting to predict in the current year, by adding them up over all the subsections of the population and adding them up over the whole of the week. We end up getting a correct, unbiased estimate of the number of registrations we would expect in this week. Now, this disadvantage of this approach are the opposite of the one we just considered a few minutes ago. First of all, this requires non-trivial modelling and very careful explanation. So that immediately makes it a bit difficult to use when you're interfacing with the public. And this is one of the reasons why there's quite a lot of preference for the average approach, even though that can actually be misleading. However, once you've actually calculated things using the mathematical model, its interpretation is then very straightforward. You just take the results directly. You expect this number, we observe this number, therefore we've got this excess, which is the difference. And crucially, because the underpinning method is basically correct, so it doesn't have these biases, it's fairly easy to extend it to other settings and scenarios. So basically, knowing that this method will give the right answer, we don't have to worry, regardless what we shift to, whether or not the new thing we're thinking about might have biases in there that we don't know about. So basically, there are big advantages from the mathematical modelling side. Okay, Sharmani, next one, please. Okay, so we're going to use the approach we're going to use is called quasi-Poisson modelling. Simple counts and rates are naturally what's called Poisson distributed. And to know what I mean by that is if you look at those, the middle two distributions, those histograms on the right-hand side, they both show a Poisson distribution. The one on the left shows this is a completely randomly generated distribution with of 10,000, I think, observations with an expectation of 20 deaths. And the one on the right is the same, but for 2,000 deaths. And basically, the thing to notice is that both these Poisson distributions look extremely similar. And in fact, the only difference between them you can see if you look at the scale at the bottom. Whilst the scale goes from 0 to 40 on the for the 20 expected deaths, it goes, and so it's got a span of 40. The span on the right has got 400 as its span. So basically, the reason for this is that one of the key features of the Poisson is that its standard deviation goes up with the square root of the count. So basically, as consistently as your mean goes up, your expectation goes up, your standard deviation gets wider, and it's wider by the rate of square root. All right, so we'd like to do a Poisson model, and the way we're going to actually do it is if we look at the top line where it says link prediction function. So basically, we're going to fit a model that's going to predict not the number of deaths, but in fact the log of the number of deaths, or in fact the log of the rate of death. So that's what we're actually going to predict. And we've got all those components in the model that we've mentioned already. And just showing here is the components for the effect of day. So basically, over the whole of the year on average, if the day is a Monday, it will it'll subtract 0.0245 from the expected log of the rate of death. Tuesdays will increase it by 0.1217. Wednesdays will also increase it, and Wednesday and Thursdays decrease it. Friday is effectively the baseline and is assumed, therefore, to have no effect on the log rate of death. Now, the key point about this means that the Tuesdays have on average have the highest rate of death, of registered deaths rather, and because we work on a log scale, all of this is multiplicative. And so what this means is, all else being equal, if it's Tuesday, the predicted deaths increase by the exponential of 0.1217, which is about 12.9% higher. So basically, Tuesdays tend to have about 12.9% more registrations than Fridays. The bottom line now, the overdispersion. In fact, in real data, typically the relationship between the mean of the Poisson and how spread out it is, because there's a lot of random things you're not taking account of properly, the distribution gets wider, and therefore you can't assume it's a one-to-one relationship. And so by modeling with the quasi-Poisson distribution, it allows you, as well as specifying, working out how many deaths you expect, you also can allow the standard deviation to be bigger if that's required. Next slide, please. Okay, so the final point, which is important, is that we need to be able to, once we've got our predicted baseline, we need to have some idea of how uncertain that is. And if we think again of those effects, the Tuesday effect, for example, I showed you, then the Tuesday effect was 0.1217, had a very small standard error. This allowed us to calculate the 95% confidence intervals for that as being the estimate plus or minus nearly 2 times the standard error. On the log scale, this gave us 0.1202 to 0.1232. And on the multiplicative scale, this means that the range, 95% confidence range, is that Tuesdays increase the risk of death between 12.8% and 13.1%. Clearly, this is very narrow. And so it sounds as though our model must be predicting the the rate of death extremely closely. But for example, if the rest of the model predicts 300 in a particular subgroup, then this 95% uncertainty coming in from the Tuesday effect isn't simply 12.8% to 13.1%, but rather we have to simulate from the distribution saying, if we are expecting there to be 270 deaths or whatever, then the expectation, the range we get from that is much, much wider. So in fact, the 95% prediction interval is not 338 to 339 deaths, but in fact it's 270 to 414 deaths. And so this needs to be incorporated into what you do. Sorry, my final slide. I'm just going to quickly say, very quickly, there are two. The negative binomial model could have been used instead, and often is, instead of the quasi-Poisson, has similar characteristics. We could have used Bayesian approaches, a wide variety of those, to take account of additional information. And then a final point to make is that it's tempting to say, why can't we just use a standard normal regression model to do this? And the answer is that that's actually not the correct distribution here. And because it's so easy nowadays to do things like fitting quasi-Poisson models, really there isn't much of an excuse for using standard normal regression models in this setting. Okay, Sharmani, over. So
sorry. I'm on mute. So just one quick slide about other considerations before I hand over to Seb. I mentioned earlier about data linkage. When you're thinking about the subgroups, you really do need to start thinking about the data you're linking to and the quality of that data. And the potential issues that may come up as a result of the quality of the data. So an example being, we obtain our ethnicity data from HES records. So for our ethnicity models, we've got ethnicity identified in HES in theory by the patient, but often by the healthcare providers, and then in the underlying denominators, so we're calculating rates, the denominators are from census data where it's a head of household. So we have seen some issues in the comparability of that data to, say, for example, ethnicity rates that are used census and on census. So keeping in mind those sorts of things. You also may come across missing data. So when we did do the linkage to the HES ONS linked mortality file, the HES ONS linked mortality file does miss out some deaths among those who've never attended hospital and were therefore not able to be identified. So you may need to think about the way in which you deal with those missings so that the number of deaths can match up to whatever your total deaths file looks like, and imputation methods for that. And then also often you'll come across certain subgroup analyses where you don't have denominators for the populations. And this is the case for us when we look at cause of death and place of death analyses. I'm sure it's easy to understand that we can't estimate the population denominators among those that have died of dementia because we just don't know them. So in this case, what we've used in our models is the total populations as the denominators to create the rates. So there's a slightly different interpretation when you're looking across the cause of death and place of death analyses, in that someone can't die of another condition if they've died of dementia. So we couldn't put them in the same model. So you need to look at all of the different outcomes together and understand that, particularly for place of death, for example, we can see fewer deaths occurring in hospital and more occurring at home. And we'll illustrate that as we go through the report, but I thought I'd flag it early just while we talked about modelling. But over to Seb now. Oh, yeah. Sorry. Yeah, Seb, do you want to do the summary?
Yeah, it might. Thank you. Yeah, it might be. Can you click through to make them all appear, please? Thanks. So this is just a very quick recap of what Paul and Sharmani have just talked about. So for our model, we have used date of registration, not date of occurrence. We model rates using the counts and population as denominators. We've used 5 years of historical data. We model using days of week and time of year and bank holidays as variables to account for seasonality and other effects the bank holidays have. Our model predicts or contains an age-sex interaction. We model at upper tier local authority level. We have ethnicity and deprivation and cause of death and place of death models. So age, sex interaction and upper tier local authority is one model, and then the other 4 are currently separate models, but we're in the process of combining ethnicity and deprivation into one model. We have a linear trend to account for year-on-year changes in mortality. We use a quasi-Poisson model on the log scale. For ethnicity data, we link to the HES ONS linked mortality file, and finally we in that linked data, and also in that linked data, we, because of missing data, we apply an uplift so it matches the overall number of deaths in the baseline for the all persons model. Okay. So this is a short bit on essentially communicating the model. So what our model does is that it essentially produces an expected number of deaths for every day for each subgroup of the population. So we've actually got a very simple number that we're calculating, but there's so many different ways that you can cut it to present it. And this is where you have to start thinking about the stakeholders that that will be using the outputs. So throughout the project, the visualization strategy was kind of essentially dictated by the stage of the project. So we started off trying to validate the model and getting buy-in from stakeholders. So that was at the very beginning, and at that point it was quite a model-centric way of visualizing. So in the top right, you can see a chart where we present the expected number of deaths each day compared to the registered number of deaths each day, and essentially that was good for us to see that the model was doing what we wanted it to do. But as time developed, you could kind of see that we were having more conversations about how we were presenting the data rather than interpreting it, and so we had to start readdressing how we were doing it. So we decided to move to presenting weekly excess deaths, which is the number of deaths above what the model was expecting. So we decided to align our weeks with weekly deaths that ONS were publishing, which people were quite familiar with at the time. And the visualizations we've produced are kind of designed to be very digestible very quickly. But in the end, they actually give very little information about the model, like the expected deaths coming out of the model. So that's more of what we've called a user-centric approach. In the weekly chart, so in the bottom right, we focus really on excess numbers, but we also find that the ratio is very important too. But in those charts, we present them within the ratios of registered deaths to expected deaths in brackets above the charts, above the bars. And then for each type of subgroup, we produce a cumulative pair of charts, which you can see in the bottom left-hand side, where on the left it's total numbers of excess deaths, and on the right you've got the ratio. And this is a good example because this is, I think this is for ethnic group males, where you can see actually the bottom bar on the left-hand chart is the white population, and there's been a lot more deaths within the white group, but actually the ratio of registered deaths to expected deaths is much bigger in the other 4 ethnic group categories to white, which is an important finding. Next slide, Sharmani. So I think throughout the project, as it evolved very quickly, the scope, we started off trying to just build a model for England to predict the number of deaths each day and compare it to what was being registered. And as the project grew traction, our stakeholders started wanting additional kind of subgroups and models being produced. So this is a slide really about how to handle kind of rapidly evolving projects, like within the coding. So we needed kind of a coding strategy that was robust to changes. So like within a few weeks, we'd gone from one model for which was age and sex, and modeled at upper tier local authority level, to I think about, probably about 20 models when we were including different models for different groups of underlying causes of death, which we'll go through in there when we show the report next. So yeah, so how to handle quickly changing code is quite daunting, because you could end up building up thousands of lines of code, and a change at the very top can have massive effects downstream, which you might not see until months later, where someone questions a figure that you're presenting. So we used quite a lot of principles from reproducible analytical pipelines, which is a concept growing within like government analytical groups. So the main parts of it are to make our code, or use open source software, use version control like Git to manage the code, functional programming to kind of reuse repetitive bits of code for different purposes, and inbuilt testing. So the code on the screen is probably the 8 lines of most important code in the whole project, which checks that our input data always makes sense when it runs through that bit of code. It's very simple, and it's just checking for the right name, the right fields within the data set, the number of records are what you're expecting, the combination of different fields are unique, everything, there are no NAs in your data, and everything's positive in a particular field. And it just the number of times where we'd make a quick change and then that would stop the code because it's identified something gone wrong halfway through, has saved us a lot of challenges. Okay, next slide. So I think I'm just going to pass over to Sharmani, but this is just to summarize the report and decisions we made about it. So we originally started reporting, creating this report as a kind of update for our immediate stakeholders, which were the kind of incident directors. And we just, so the report was developed using R and R Markdown. And so we just quickly developed an HTML report, which is very simple to do in R Markdown, to just like simply communicate where we were with the work. And as time grew on, we decided to turn this into the actual report that we're going to share publicly, because you could use interactive elements such as selecting the regions and different underlying causes of death. And we actively chose not to turn it into PDFs, which we had a lot of requests for, partly because of guidance from government digital service, but also because I think HTMLs are essentially a little more accessible. Just to note that we haven't tested the report to meet the accessibility standards that have recently come into play. Okay, Sharmani, over to you to go through it.
Okay, so I will do a short run through. It's a very long report, and I think Seb and I and Paul have discussed more recently about some potential changes because of the length of the report to the formatting, but that's to come in the future. But at the moment, I'll just go through a few key parts. So the top, as a menu, you can navigate through the report, for example, onto regions and then across regions and have a look at excess. But I'll start.
Sorry, Sharmani, I'm not sure if the report's showing at the moment. I can see the slides still, but I can't see the report. So I'm not
sorry,
sure.
That's me getting used to Teams. Let me try again. I'm going to start again. Do you have it now?
Yeah,
Great, thank you.
That's great.
Okay. So sorry, I assumed you'd seen that. So we've got at the top of the report, there's different ways you can navigate through the report and the menus here. And I mentioned before, you could go to region and click through the different regions to see excess in each region. But I'm just going to just highlight some sort of interesting results basically, because this is publicly available and you can access it as you like. But so we first present excess mortality from all persons, all ages in England, and that's the first chart we present, and that's by week. And you can see here the shape of the pandemic period, and then we went into a period where there were fewer deaths than expected for a number of weeks, and we're just coming out of that period now. And just to highlight, Paul spoke and really nicely described the issues with using a 5-year average and bank holidays, and obviously Easter was a major issue and we've accounted for that, but actually the August bank holiday was a particular issue because it was around then that we were really starting to be nervous around increases in excess. And during that week, because of the bank holiday, the one particular group that uses a 5-year average showed a 700 death excess that week, which is quite substantial, but it was just an artifact of bank holidays. So we were able to sort of model that out, and our data for that week showed fewer deaths than expected. So you can see now things are changing slightly. These fewer deaths than expected may be because we're having a low mortality year anyway in 2020, and almost any model sort of overestimates the baseline slightly, but it's also in combination with potentially some mortality displacement that's going on, where people who would naturally have died here, or their deaths were brought forward. So I said before, the orange indicates a death with a mention or underlying cause of COVID, and the white is with no COVID cause on the death certificate. So again, just one other thing to highlight is there's been a lot of media attention around COVID deaths, and these are not defined with the 28-day cutoff. These are about a clinical on the death certificate, what's on there. So there's someone who's making a decision, clinician making a decision, rather than a cutoff of number of days since a test. And COVID, the ICD code for COVID will include both the if someone's had a test, or if it's if someone's suspected with no test. So moving past the weekly, we also produce cumulative chart that just shows over the period since March 20th, the number that we observed versus the number we expected. And here we've got 53,318 excess that we calculate using our model, which is 1.24 times the number of expected deaths in that period. And just under 50,000 of those were COVID. We then break down deaths over the weeks by males and females and different age groups. So this is males. Here, I think Seb showed an example of these charts. These are the cumulative deaths over the period up until the date of the report. I should also mention the report's released at 2 p.m. every Thursday, so there'll be an update that goes to September 11th coming out at 2 p.m. today. But this here you can see the observed deaths among each age group, and then the ratios on the right. We omit any ratios, we censor them if they're not different from, if there's no significant difference from one. So that's for age groups. Males, and maybe something worth noting in this one is the fact that you have the highest relative increase in mortality has been among younger males aged 45 to 64, not necessarily the older age group. And just looking at females, females here, again, the highest is in that 45 to 64 in terms of the excess, so the difference from expected. But obviously the largest volume, actual crude number of deaths has been among the oldest age group. We've produced tables that have all the numbers in, so people can use those. This here, now we're looking at, this is by ethnic group for males. Here on the left, Seb showed us an example of this chart, I think, is the crude numbers, but on the right you can see black males have the largest relative increase in mortality during the period, compared to white with the lowest. And in females, we see some slight differences in the way that mixed and other are estimated, but again, if you can, it does show that other have the highest relative increase. We do think that's potentially a problem with the way in which we're measuring ethnicity and the mismatch between the denominators and HES, and we're doing quite a lot of work on fixing that at the moment, and that should come into play fairly soon. But white certainly has the lowest relative increase by ethnic group. Deprivation, so this is the deprivation chart. So the least deprived are the wealthiest at the bottom here and the most deprived at the top. This isn't necessarily what you'd expect. What we do see, I can tell you, is that when we split this into under and over 75s, we see that in the under 75s, there's definitely a relationship with deprivation in that the most deprived are very much more affected than the least deprived. We believe that what we see here is a result of the fact that people who are dying, the vast majority of people who have died over in the last period have lived in care homes, and care homes are not necessarily reflective of someone's lifetime deprivation and the postcode, sorry, within a care home. So deprivation is measured by IMD of area of residence at the time of death. So we did some analysis recently, splitting up into under and over 75s, and we see that relationship's completely different and very much a gradient from the most deprived being the most affected and the least deprived being the least affected, and it's a very strong gradient. Regions, we look at 9 regions, and then we can compare these regions with London having the largest relative excess over the period. Northeast, should I say that for Paul, has 1.25 times the excess. Everyone's, I'm sure, looking at their own particular region there, if you can see those small numbers. Then we look at deaths by underlying cause. So this list of underlying causes is constantly evolving, and we're sort of receiving requests from stakeholders to change or add certain things. And for example, these are what we believe are important at the moment, and these may change over time. But we look at ischemic heart diseases and stroke and other circulatory diseases. And one of the things that really strikes me when I look at these is that we're not seeing a long-term decrease. And it's not the shape of the pandemic in the way that, say, for example, dementia and Alzheimer's. The shape of these is very much similar to the shape of the total pandemic. The other one that I'll highlight here is cirrhosis and other liver diseases has been high throughout. And there's different potential explanations for that as well. Cancer, so people often want to see cancer, but I can show you that cancer, we haven't seen, I don't think we're seeing the result of the lockdown yet, and this is something we're going to look at longer term. And just to note as well, we don't have data for suicides because these are often delayed by a long coronial inquest. So we don't have that in the data at the moment. This will come when they're registered at a later date, possibly a year in advance. So of these causes of death, you can see that dementia and Alzheimer's has had the highest increase compared to expected. And then finally, we also look at diseases with mention. So for example, diabetes isn't something that's usually the underlying cause of death. So we thought it was important to look at it as a mention, as well as acute respiratory infections. Again, this one looks like the pandemic and Alzheimer's. And finally, place of death. So place of death has had a lot of media attention. So like I said earlier, these are the population denominators for the full population because we can't estimate who's going to die in certain places. So we've got here, you can see that people are dying in their own home and have been since the beginning of the pandemic, more so than we would expect. There's been more deaths in care homes in the earlier part of the pandemic and fewer since the sort of June time. Hospitals have saw very much an excess in deaths during the pandemic period, the first wave of the pandemic, and very much a deficit since then. So we think that these deficits are sort of mirrored by those that are dying in their own home. And also worth mentioning, if you look at the figures for hospitals, this excess is COVID is 3 times what that excess is. So actually there were far fewer people going into hospital and dying from other things, and COVID filled up their spot and then gave the excess. In terms of what people were doing for their death, far fewer people went to a hospice and have done this since March 20th than we would expect, and died within hospices. And we're seeing more people dying in other places, potentially ambulances or public places. So that's the end of the report. Really, we linked to previous reports down the bottom, and there's a methodology document that goes with it. But I think that's the end of our presentation, and I'll hand over to Joe, possibly.
Yeah, sure. No, thank you, Sharmani. That was great. We are running out of time. We do have a couple of questions if you guys are okay to stick around for a couple of minutes, but we can try and wrap things up fairly quickly because I'm aware we have reached past.
Joe, the other thing is if there are key questions that people would like to be asked, they could potentially could they be sent on to us, Sharmani, and for us to look at?
Yeah, absolutely.
Yeah.
Okay, sure. So yeah, maybe seeing as we've kind of reached the end here, that might be best. Thanks for those who've posted some questions, but we'll pass those on and we'll try and get them answered for you if that's okay. There is a link to the report in the chat as well. I think Seb posted. I can repost that. But yeah, just to say thank you very much, Paul, Sharmani, and Seb for that. It was really interesting, really valuable, and yeah, thanks for taking the time to do this.
Before everybody goes, can I ask one quick question? And that is there any comparable statistics? Is there any comparability between this and other European countries, for example? And could it give insights into very different sort of statistics that are coming out of countries like Sweden?
Paul, do you want to take that? Or?
Well, I mean, I think if you talk about the Euromomo and stuff like that, I think it would be helpful if you do that.
Yeah. So there's ways, and we do plan to use this model to compare between countries. And there are ways to do that, which we're putting into place at the moment. And we're going to start with the 4 nations and move on to other countries. I think all-cause mortality, excess all-cause mortality is the appropriate measure for comparability. And I think we've seen why with the different ways in which you define a COVID death if you're just looking at case data. Yeah, I think we've got Euromomo is one particular source that at the moment you can use, which we contribute to it at PHE, which is a slightly different model and doesn't have denominators in it, but it's I think it's similar to a quasi-Poisson model, and that's one there will give you more comparable measures between the 24 European countries that contribute to Euromomo. But we haven't started the international comparisons using this model just yet. And I think you may be aware the ONS did an international comparisons paper using a 5-year average model. But it's very, very interesting. And Paul and myself contributed to reviewing that and know it quite well. So it's quite a good comparator.
Joe, could I ask you quick? Is there any reason why, if anybody has got a burning question, when I'm certainly happy to stay on for
no, I'm happy to keep going.
Yeah. Okay, great. So
yeah, if anyone does have a question, please do let me know or raise your hand. There is a couple in the chat. VJ was asking, to what extent is the BAME effect due to better recording of ethnicity in more recent years? Have you looked at the percentage completion of this field over the reference period?
Yes, so that's something that a group in our population health analysis team are doing at the moment, and there's quite a lot of work going on there around coding over time. So the way in which you select the HES record, we're modifying so that we can get a better, more accurate result from the ethnicity field. And that includes time. I hope that I've answered that.
Thanks, Sharmani. And Kieran was asking, does the COVID death definition include just those mentioning it in 1A, 1B and 1C, I think, in the report, or is it in section 2 as well?
Good. I think it's any cause of death. Do you want to say?
So did you hear the question?
Sorry, I was on mute.
The question is whether the cause of death is a mention solely in the 1A, 1B or 1C, or whether it would also include mention in 2.
Section, what's section 2?
This is
a death certificate section, or a death, or the, is that what it's referring to? The death.
Yes, I was referring to the death certificate. So death certificates are subdivided usually into section 1 and section 2, where section 1 is direct causes of death, and section 2 is other known conditions that may have been related but were not a direct cause.
Right. Okay. So yeah, it's a COVID mention refers to any position, so section 1 or section 2. But I think I can't. Sharmani, you know better than me, but I certainly at the beginning of the pandemic, I think it was within the first 3 months, 96% of the deaths which had a COVID were in the section 1. I don't know what that figure is now.
It's reduced over time quite considerably, but it's down to, I think, somewhere around 80% at the moment. But yeah, if we include a mention, it's anywhere in section 1 or section 2, or if it's underlying cause, it has to be. It's the algorithm selected, the WHO algorithm for selecting the underlying cause, and I believe that's from section 1, but it can be trumped by certain things based on that algorithm.
So could I make an extra point, which is that it strikes me that, came right back to what I said at the start in terms of setting the scene. One of the really useful things that could happen before another outbreak was to occur would be to rapidly think about what the coding of death certificates should be, because it really, basically initially it was difficult to know how to interpret things because there was no consistent necessary way to do this. And I think that really focusing on the coding would be helpful. And Nick, am I right, Nick? Is this something you mentioned in terms of, was that about SNOMED stuff? Or was that something different?
Sorry, what do you mean about which codes are used in GP?
Yeah.
Well, there does seem to be a variety of SNOMED codes which are available for use in all systems, actually, and because SNOMED is a very comprehensive classification. Well, it's a conceptual classification of diseases and problems and histology and organisms and things like that. People code the same thing using different codes. So we did try in the faculty to offer restricted hot list, if you like, of codes to use in COVID, but I'm not sure that was adopted in any way, in any coherent way. So coding consistency is very, very difficult to get right.
But it seems to me that in terms of, again, for a future pandemic, I think that one of the things that the Faculty of Clinical Informatics should do is really push this in the way that Nick's saying, because it really, if we could be, if you look to the questions that we received when we started doing this, an awful lot of the questions were about how code was being coded, and we obviously had no capacity to change that at all. But if someone behind the scenes was pushing for this to be done as effectively as possible, then I really think that would be a big strategic advantage over where we are at the moment.
Yeah, I agree, and it would be good if we did have the foresight and bandwidth to be able to create a kind of special interest group in pandemic classification or something like that. That might be valuable.
That sounds like a good job for Dido to deal with.
Did we have any others? There was a question from Bill Simpson. Can you compare dementia related to all care home related excess mortality?
So I don't know whether you want to do this, Paul. It'd be great. At the moment, we don't have the denominators. So it becomes quite difficult. But we can certainly describe this, and we have put together a load of descriptive data for an internal presentation tomorrow around comorbidities. There's also we've done it. This is outside of this piece of work, but we've linked to HES. We've got HES data linked to mortality data, not just HES ONS for ethnicity, but actually to look at comorbidities. And there's quite a lot of work at the moment there that might be able to look into place of death, and that's certainly going to be more. There's going to be more of that released into the public domain over the next month or so, or end of October, I'd say. But I expect that would come out of that work rather than this one, this particular model.
Thanks, Sharmani. Does anyone else have any other questions? Feel free to put your hand up or just unmute yourself and ask the question if anyone has anything they'd like to ask. Okay. It looks like that may be everything.
Sorry, Joe. Got a quick question. Really enjoyed that, everyone. Just wondered if you shared this model and data with Public Health Scotland.
Yeah, yes, as in we have been in touch. It's been shared among the chief medical officers across the devolved administrations, and I have met with the DAs to discuss our plans and shared the plans, and they have offered the code across the DAs. And I think the current plan is that we come together a little bit later on in the picture to look at comparisons. But if you think that Public Health Scotland should be looking more into it, you can always nudge them to get back in touch with us, because we're very willing to sort of help people produce similar estimates.
Fantastic. I may well take you up on that, Sharmani. Thanks.
No problem.
Thanks, Chris. Is there anyone else? Anyone else got a question? Okay, I think that's great then. Yeah, and yeah. If it's okay, we can. If anyone else has any other questions, follow up with me, send me an email, and I can pass it on to Paul or Sharmani or Seb. Yeah, thanks again, everyone, for joining.
Thanks to you for it's been organised really well, Joe. So thank you very much.
Thanks, Paul.
Yeah,
Paul.
thanks, Joe.
No worries. No worries.
On behalf of the faculty, thanks very much to Paul and the team from Public Health England. That was great.
Thank you.
Okay then. All right then.
Thanks,
Bye.
everybody.
Bye.